Hi, everyone. How's everyone doing today? Thank you for joining us. Today, we have a monthly chat special edition, Surviving and Thriving in the Tripledemic, what you need to know to protect yourself from COVID, influenza, and RSV. We will have our special guest, Joanna Schaenman. She is Professor of Medicine, Division of Infectious Diseases, David Geffen School of Medicine at UCLA Health. We have a disclaimer. The information contained in these topics is not intended nor implied to be a substitute for professional medical advice. It is provided for educational purposes only. The UCLA health system nor the providers of the information contained herein, including all parties connected with this event program, cannot guarantee the accuracy of such information. You assume full responsibility for how you choose to use this information. Always seek the advice of your physician or other qualified healthcare provider before starting any new treatment or discontinuing any existing treatment. Talk with your healthcare provider about any questions you may have regarding a medical condition. Nothing contained in these topics is intended to be used for medical diagnosis or treatment. This is our circle of core. I'd like to introduce to you all of our members, and we have actually many more. So we will be updating this collage. This is our contact information. Please connect with us. You can call us, email us, visit our website, and follow us on Facebook, Instagram. I'd like to introduce and present to you our Rose Parade, Tournament of Roses Parade float on that we will be presenting on January 1st. So we applied to be a part of the Tournament of Roses Parade, and we actually were accepted. So out of about 35 floats, we are one of them. So the kidney disease awareness cause is huge, and we want to make this It's going to be an amazing opportunity for us to promote kidney awareness. Our theme is Gift of Life, a tune that never fades, as you see on the screen. We have our green ribbon there. We have our core kidney logo. We've got a hummingbird that's leading the float. So you will be hearing a lot about this float in the next few weeks and months. We also have a rose campaign. This is for the Tournament of Roses Parade. You can buy a rose and or a dozen or two. And you can do this by texting "buy a rose" to 41444. And you can honor a loved one. And we will have a digital wall of names that for the people that we will be honoring. So I just wanted to pass that along, and you'll be hearing more about that as well. So now I'd like to introduce to you Dr. Joanna Schaenman, and she will start our program.
Wonderful. Thank you for that introduction. And I'm so excited to see that beautiful float. I can't wait for the Rose Parade. It's a real honor to speak to this group, especially about a topic that I'm very excited about, which is how you can keep yourself safe. I'm going to speak for about 20 or 30 minutes, so you can put questions in the chat or hold your questions to the end, and then I'll try to get through as many questions as I can. All right, I'm going to share my screen. Right. I'm going to start presentation mode. All righty. As mentioned, when Dr. Rastogi invited me to speak and to talk again about COVID, I said to him, you know, there are other viruses out there, and I really want to talk about all three of them. This is the time to do it. And that's why I'm going to be talking to you today about the Tripledemic, by which I mean COVID, influenza, and RSV. So here's some of my disclosures. I do have some consulting work for One Legacy and Medcare, which is a tissue bank, as well as some clinical trial funding, and I am on a data safety management board. So we're going to talk today about COVID, its impact in patients with transplants as well as end-stage renal disease, talk a little bit about influenza, RSV, vaccine recommendations, and end with developing an action plan to keep you safe through the winter and beyond. So, you know, I recently published an article on vaccination called From Cowpox to COVID. And I do think it's very interesting to just look back on how far we've come since 1796, when the first vaccine was invented by Edward Jenner, a live vaccine that was harvested from cowpox pustules that he used against smallpox. This was followed by Pasteur's inactivated vaccine for rabies. Some of you may remember the work of Sabin and Thieler in the 30s, when a live attenuated virus was developed for polio, as well as the MMR to protect us against measles, mumps, and rubella. The 80s really saw the era of developing recombinant proteins for use in vaccinations, including pneumovax, the flu vaccine, and hepatitis B. And we're now really in the RNA vaccine era, where we're using mRNA technology against SARS-CoV-2. And maybe there'll be applications of that RNA vaccine approach for other viruses. So what are the vaccine recommendations for transplant candidates and recipients? As you may have guessed, I'm going to be focusing on the bottom three, but just wanted to bring up the fact that you should also have your MMR, that's a live vaccine, so it's pre-transplant only. Tdap to protect you against tetanus, and pertussis, which is whooping cough, that's every 10 years. If you're over 50, like me, you should have your Shingrix vaccine to protect against shingles. We also recommend Prevnar 20. That's a once-in-a-lifetime vaccine, in addition to Pneumovax, hepatitis A and B, the HPV, human papillomavirus, if you're young, if you have a complement deficiency, asplenia, or plan to get a complement inhibitor such as eculizumab, the Haemophilus influenza and meningococcus vaccines are recommended. We also recommend COVID, influenza, and this just in, RSV vaccine if you are over 60 years old, or that should be considered. All right, so let's jump into COVID. I think it's always important to start talking about COVID with the reflection on the big impact it's really had, especially in transplant patients. This is just a review of many studies showing that if you look at folks who are hospitalized with COVID vaccine, looking at transplant patients, the majority are really kidney transplant recipients. Their hospitalization rate, intubation rate, and death rate are higher than non-transplant patients in many studies. And in addition to being admitted to the ICU, having COVID can damage your heart. It can cause kidney damage and chronic kidney disease. And changes in immunosuppression can impair your kidney allograft function. In addition, several other comorbidities in addition to transplantation have been found to be associated with poor outcomes, and those include increased age, end-stage renal disease, and diabetes, as well as obesity and lung disease. So COVID, unfortunately, remains a problem in California. I downloaded these slides from the state dashboard just today. You can see that new hospital admissions total 600,000 over the state, with a daily average of 277, an average of 18 deaths daily, and the positivity test rate is 7%. Now, we saw a nice little surge in August, end of August, early September, right when kids went back to school. And when folks were coming back from vacations, things are leveling off or declining just a little bit. But I'm confident that as the weather cools, it's easier for viruses to stay alive for longer on surfaces. And certainly as folks start getting together for winter holidays, such as Thanksgiving and Christmas, that these numbers are going to go up, way, way up. And that's exactly what we saw in 2022. So when we think about COVID in 2023, it's kind of like the good news, the bad news, or cup half full, cup half empty, depending on whether you're an optimistic or a pessimistic person. The good news is COVID in 2023, compared to, say, the terrible times of 2020, is that vaccination is widely available. COVID vaccination has been shown over and over again to be safe and to be effective in preventing severe disease and death, even in transplant recipients and even in patients on dialysis with end-stage renal disease. In addition, we do have treatments which are widely available, such as remdesivir and baricitinib, and these have been shown to have a positive impact on preventing death due to COVID. The other good news is that the newer variants seem to be less pathogenic than the original wild-type strain. Now, that's difficult to know for sure because certainly the population has more immunity, but I think overall it seems that these newer mutations seem to be causing less severe disease compared, again, with 2020. The bad news, however, is that many patients remain either unvaccinated or undervaccinated. The other bad news is that often treatment requires hospitalization, especially for transplant patients, and treatment is not 100% effective. So even though we have treatments, COVID definitely continues to cause significant morbidity and mortality in transplant patients, in older patients, and in patients with chronic medical conditions, including end-stage renal disease. And the other bad news is that these newer COVID variants, although their disease they're calling maybe a little bit milder, they're definitely more transmissible than the wild type strain. And so they're very easily spread from person to person. So just to look briefly at the story of the variant. So we started with the wild type. Then we quickly had the alpha strain that was back in 2020, followed by beta, gamma, and then delta is what caused the big wave in October 2020 and in the winter months of 2020, where we really saw high levels of COVID, hospital admissions, and death really worldwide. 2021 and really starting in 2022 is when we're really now in the era of Omicron only. And Omicron has become completely dominant over the entire world. Every virus that we sequence seems to be Omicron. So now we're talking about subvariants of Omicron that have these very awkward names that start with XBB. So the nomenclature started with this XBB.1.5. Then we had the 1.16. And the most recent strain that seems to be spreading is XBB 1.9.1. So these are variants that, only an epidemiologist could really love. But point being is that we've come quite a long way since the original wild type strains. And we're really in a COVID era right now. The good news, though, as mentioned, is that we do have vaccines. Pictured here are the bivalent vaccines. But what you really need to know is that since last month, September 2023, we have new vaccines that are specific, not just for Omicron, but for the XBB strains. And data shows that they are cross-reactive against the 3 most dominant variants that are currently circulating in the US and worldwide. Now, many of you, when I see patients in clinic, they tell me I had 3 vaccines, I had 4 vaccines. The reality is that now we're not counting. It doesn't matter how many vaccines you had in the past. What matters is, did you get the latest vaccine? That's all I'm interested in. So we've got the Moderna vaccine, we've got the Pfizer vaccine, and they're both available now with the new 2023-2024 variants. And if this sounds familiar to you, that's because this is exactly how we're doing flu vaccines. You don't tell me how many flu vaccines you've had. The point is you need to get the seasonal flu vaccine that's applicable to this season's viruses. Now, we really don't know for sure. This has been a rapidly, changing field over the past few years. But I think we're going to kind of get into a habit where every year or maybe as frequently as every 6 months, we're going to update our COVID vaccine and have a new vaccine available that is tuned to the variant that is circulating. Now, these Moderna and Pfizer vaccines, again, we've got 3 years of safety data. They're very well tolerated. They have minimal vaccine reactions such as arm pain, 24 hours of feeling unwell, sometimes with fever. They are both FDA approved. But if you're a person out there, for whatever reason, you prefer to go old school with a subunit vaccine, we do now have a subunit vaccine for 2023-2024 COVID called Novavax. That's a US company that's based, I believe, in Virginia. And it is now approved under a FDA EUA. So if you prefer to get a subunit vaccine, or maybe you had a bad reaction to an RNA vaccine, that is now available as of last month. So the recommendation is that if it's been more than 2 months since you got your last COVID vaccine, that you should get this new virus vaccine. And if you just had COVID and just recovered from COVID, we're recommending that folks wait about 2 or even 3 months from your last natural infection before you get the COVID vaccine. But even if you did just have COVID, it is essential to get that vaccination. Now, why? It's because the naturally occurring T cell and antibody response is going to wane over time. Starting at about 3 or 4 months, those antibody titers are going to go down. That's the perfect time to get a vaccine that's going to boost that natural infection response and keep you protected for many months after your natural vaccine. So good news, bad news. When we study hemodialysis patients and kidney transplantations versus healthy controls, we do see that if you're on hemodialysis, your antibody response is lower than a healthy person who doesn't have kidney disease. And if you're a transplant patient on immunosuppression, your antibody response is going to be lower still. However, when we look at T cell responses, they're actually pretty equivalent between folks on hemodialysis and healthy control. So that's good news. They are lower in kidney transplant patients. There's many publications out there about this. There is a non-response that's been observed to primary vaccination in kidney transplant recipients, but those vaccine responses are probably going to get better as more and more transplant patients who have survived COVID are going to be experiencing the vaccine not as a novel antigen, but as a booster. So it's not great news. If you're on hemodialysis, you're a transplant patient, your vaccine response is less than a so-called normal person. But the good news is that even with an impaired vaccine response, there's very strong data that vaccination can still decrease your chance of getting COVID, decrease your chance of getting severe COVID and requiring hospitalization and dying from COVID. And this is some data from early in the pandemic, but I like the visual abstract that they did. They show that if you were unvaccinated, your chance of mortality as a transplant patient was 12%. But if you had had 2 doses of the vaccine, and again, this is 2020, 2021, that mortality rate was decreased. And that has been shown in multiple studies. This one's from England. There's a study from UC San Diego that showed the same thing. And there's also data from folks who are on dialysis or with chronic kidney disease that even though the vaccine response may be tempered, may be attenuated, it still has a clinical impact that's associated with a lower risk of getting COVID, lower risk of hospitalization, lower risk of death. So when it comes to vaccination in folks with comorbidities, there's no question that half a loaf is better than none. So it's important to get that COVID vaccine. Now, what about influenza? I think a lot of people find influenza very boring in the post-COVID era. It's like, so what? Do we really care about flu anymore? And the answer is yes. We still need to worry about flu even in the post-COVID era. And I picked this graphic just because I like this picture of a flu virus cracked open so you can see all the material inside the capsid. Okay, so old but should not be forgotten. So these little pictures of California, this one I just downloaded today, it shows the influenza activity level in California as of, I guess this is now about 2 weeks ago. So you can see that right now, it's still pretty minimal, starting to heat up in the Inland Empire. However, looking back to last year, it was really by the end of November is when we were hot in Southern California with very high influenza activity. And that's when we were seeing moderate activity in Los Angeles. And by December, throughout the state, we were in high activity. So don't delay. We're not seeing a lot of flu right now, but we will probably in November. So this October is a perfect time to get your flu vaccine. Now, we know that the flu is a very important cause of morbidity and mortality in transplant recipients and patients with kidney disease. Why is that? It's because those groups are more likely to get pneumonia after they get the flu, either a viral pneumonia directly from the flu or what we call a secondary bacterial pneumonia. And that's what's causing the hospitalization and the death after you get influenza. Now, this was a nice study using inpatient data from the United States. And what they found is that if you had either end-stage kidney disease or if you were older, there was a significant increased odds of dying due to influenza. The other big cause was heart failure with a 1.67 increased death, as well as in immunocompromised status, including transplantation. So don't just take my word for it. Here's one of many papers that I could have pulled showing that if you're older, or if you have kidney disease, you're really at increased risk from influenza. Now, in terms of efficacy, similar to the story in COVID, unfortunately, the flu vaccine is less effective if you're either on dialysis or taking immunosuppression. One ray of light, however, is that we do have something called the high dose vaccine, and that is more effective than the standard dose. That's recommended for patients 65 and up. And there is data showing that at least in transplant patients, you get a better antibody response regardless of your age, with the fold improved increase ranging from 1.5 to 2.5 with the higher dose vaccine. Unfortunately, if you're under 65, most insurance companies are not going to pay for the higher dose vaccine, even if you're a transplant patient or you have kidney disease. So better to get something than nothing. So unless you're prepared to pay out of pocket a few $100s for the high dose vaccine, I recommend the standard dose vaccine for all humans, but especially those with comorbidities such as kidney disease, especially those who are transplant recipients. And if you're over 65, get that high dose vaccine. So just like with COVID, although the vaccine is less effective in transplant patients, we've got very nice data from this study of over 600 transplant patients who were diagnosed with influenza, that the odds ratio for pneumonia, hospitalization, and ICU admission was significantly decreased by 0.3 if you were vaccinated for influenza that year, and if antiviral therapy, which is generally Tamiflu or oseltamivir, is initiated early. You've got an increased chance of pneumonia or ICU admission if you're older, if you have greater than 2 comorbidities, and those include diabetes, kidney disease, lung disease, and obesity, and if you are on CellCept. So many of these issues that increase your chance of having severe influenza cannot be modified, but accessing antiviral therapy is something you can do something about by reaching out to your doctors and getting tested early, and getting vaccinated is something that you can do to decrease your chance of having severe infection from influenza, getting into the ICU, or dying. Okay, so let's talk about RSV. When you look at the news, a lot of news coverage on RSV, and that stands for respiratory syncytial virus, really focuses on children. Children's hospitals filling up with RSV, young children and baby dying from RSV. But unfortunately, respiratory syncytial virus is really a problem of the young and the old and the immunocompromised. So this is just one of many articles that I could have chosen. I like the graphics. This is a group from Korea. And what they're showing here is that this is back in the pre-COVID time. So the data is a little cleaner, is that around the time when you're getting influenza in the winter months, so this is January, February, March in Korea, that's when you're getting RSV. Now the influenza is shown in blue. The RSV is shown in orange. So you can see that when they're testing hospitalized patients, there's more cases of influenza than RSV. However, what they found is that in this patient cohort, the hazard ratio, the risk of death, was 2.3-fold higher for patients with RSV compared with influenza. That's pretty significant, and that's an adjusted hazard ratio. And the variables that cause increased risk of death were increased age, chronic lung disease, and having actual pneumonia, lower tract disease. The reason for that difference is probably because we don't have good treatment for RSV the way we do for influenza. So the point is that even though RSV may be less frequent, because it's not really treatable with an effective antiviral therapy, when it does occur, it can cause significant disease, hospitalization, intubation, and death, especially in older patients, especially in immunocompromised patients. But there's good news as of this year, we have not one, but two new RSV vaccines on the market. These are both inactivated subunit vaccines. They target what's called the F protein in RSV. And this is just a little bit of data from the GSK study. This was a phase 3 randomized placebo-controlled trial, and they enrolled over 25,000 patients in 17 countries and assigned them to receive either placebo or RSV. So if you look at this Kaplan-Meier curve, you can see the folks in blue who got the placebo had a cumulative incidence of getting RSV. It looks like it's about 0.3 or 0.4%, while the folks who got the actual RSV vaccine had a much lower incidence of getting RSV, more like 0.1%. So that vaccine efficacy is 82.6% over 80%. And that's what led to FDA approval of this vaccine. Now, in terms of side effects, adverse events, they were generally mild to moderate, and they're exactly what you would expect from a vaccine, especially a vaccine that has an adjuvant. So folks did have more solicited adverse reactions, and the reactions were generally pain at the vaccine site, 60% in the vaccine versus 9% in placebo. And vaccine recipients were also more likely to report fatigue compared with placebo. But still, these were very good numbers in terms of preventing lower tract respiratory infection. And so this data has led the ACIP to recommend one or the other of these vaccines. They gave them a little bit of awkward names, in my opinion. The GSK product is called Arexvy, and the Pfizer product is called Abrysvo. They're both, I find them a little hard to pronounce, but basically pharmacies are generally stocking one or the other, probably just based on their supply chain. Both of these have excellent track records in terms of preventing RSV-associated respiratory tract disease in older patients. I just showed you the GSK data, over 20,000 participants with excellent safety data. The Pfizer product had similar excellent efficacy, over 80%. This was also studied in patients who are 60 and up. They also studied over 30,000 participants all over the world with very good safety data, with about a 1% incidence of severe, what's called reactogenicity, which is generally fever, fatigue, and pain at the vaccine site. So ACIP, and that is the branch of CDC that makes recommendations for vaccination. They're recommending that adults over 60 receive a single dose of RSV vaccine prior to respiratory virus season, guided by the patient's risk for disease and at the healthcare provider's discretion. So they're leaving it a little open-ended, but the risk factors that they mention in their recommendation are chronic medical conditions, which would be immune compromised, transplant patients, kidney disorders, lung disease, as well as frailty. And they do state that it's okay to administer with influenza, but there's no data on co-administration with other vaccines. So last but not least, and I'm getting towards the end of my slides, is masking. Now, this is a very dull topic right now. No one wants to hear about masks, but I just present to you for your consideration this data that was published in MMWR a few years ago, that if you wear a surgical mask, you have a decreased odds of getting COVID when you are inside. And so I'm just going to demonstrate my little surgical mask. I wear this whenever I'm in the hospital. I'm still wearing it in the grocery store. I make sure that I have a tight seal and that I'm not feeling the air come in around the corners there. I still also recommend, I'm looking to see if I have a show and tell. If you're in an especially high risk area, you're going to an indoor concert that's going to last 2 hours, you're on a plane, especially next to someone who's coughing and sneezing, God forbid, really best to wear what's called a respirator. That would be an N95 if you're in the hospital. I'm going to demo here. This is my KN95. I got this online somewhere, also testing for a tight fit around the nose, around the sides. Sometimes I'm going to twist this little sucker around my ear to make sure it's tighter. If you don't like the KN95, check out the KF94, which I added to this slide. That one comes from Korea and has more of like a duckbill appearance. And depending on the shape of your face and whether you have facial hair or not, you may find one or the other of those respirators more comfortable and a better fit for you. So play around with those two. Okay, so I'm at the end. So what can you do to protect yourself this winter? Number one, get the newest COVID vaccine if you haven't already. I got mine 2 weeks ago. Get the seasonal flu shot. And if you're over 65, if you're older and wiser, ask for that high dose vaccine. If you're the kind of person who likes to be efficient and just want to get her over with, you can combine steps 1 and 2. If you're the kind of person who kind of likes to ease into the swimming pool, then go ahead and stagger them. I recommend that you get the COVID vaccine first because that's already surging in our community. Wait a week or 2 and then go ahead and get that seasonal flu shot. Now, the RSV vaccine is a little trickier. That might be something that you want to discuss with your healthcare provider, but you should definitely consider it if you're over 60, if you're immunosuppressed, and if you have chronic lung disease, or if you have a high-risk job or family situation where you're worried about exposure to folks who might have RSV, like school-age children. And finally, this is less exciting, but hand hygiene with gel or hand washing, wearing a mask in high-risk situations or avoiding high-risk situations, and staying away from people who are actively sick. Those are free, cheap, and easy steps that you can take to keep yourself safe. So I'm just going to end with some fun graphics that I found online, giving you the message to get vaccinated, get boosted, get protected. Avail yourself of the fact that this winter, for the first time ever, we have vaccines for all 3 of the leading causes of death and hospitalization during respiratory virus season, which is COVID, influenza, and RSV. So it's really an exciting time for medical progress and an exciting time for prevention. So I'm going to end here and happy to take any questions. I guess I should look in the chat. Shall I do that? And
Dr. Schaenman, I can ask those questions live.
Okay, great. Go ahead.
Perfect. So I think Nanette wants to know, as a transplant recipient, does having COVID multiple times create any protection? Most recent, she had them this month.
Okay, yeah. So yeah, great question. So maybe, and I may go back in my slides here, just so I can have a little visual aid for that. So great question. So the funny thing about natural infections is that the immunity does tend to wane over time. So even if you've had COVID 2 times, 3 times, 4 times, each time you get it, the immunity seems to wane. And if you think about it, remember that COVID, SARS-CoV-2, it's a coronavirus, which causes the common cold. Now, I've had a common cold 20 times, 30 times, but every year you get the common cold again. So even if you've been exposed to COVID, it keeps mutating, and the protective immunity that you need is going to just naturally wane over time. So I don't care how many times you had COVID, you still need to get vaccinated if you want to maintain that good humoral and T-cell immune response. Now, if you just had COVID, as I mentioned, you're going to be blessed with some natural infection, natural immunity to infection for about 2 to 3 months. So if you just had COVID, it's like in September, maybe December would be a beautiful time for you to get that new COVID vaccine and keep your immune protection going through the rest of the winter. Otherwise, what we've totally seen before is that you can get COVID twice in a season. You could get it early in the fall and then get it again in the winter or early spring. So 3 months is what I would recommend to wait. I'm going to add that to my slide. Okay, any other questions? Hopefully I answered that adequately.
Yes, you did. Thank you so much. So Anna asked that she was just transplanted at Stanford 3 weeks ago, and her doctors have recommended that she wait 3 months before she can get the new COVID vaccine. She's asking recommendations to stay safe from COVID in the meantime.
Okay, so in the old days, and by that I mean, 2015, we used to ask patients to wait 3 months after transplantation before they got vaccines, especially if you get ATG, anti-thymocyte globulin. However, with the COVID pandemic, I think we've really realized that waiting as little as a month is sufficient. So I would suggest that you reach out to your transplant doctors and ask if it would be acceptable for you to get the COVID vaccine 1 month after your transplant. If we were talking about June or July and maybe we didn't have a lot of COVID circulating, then maybe 3 months is okay. But basically the recommendation is to get vaccines 1 month post-transplant during epidemic situations. So if the vaccine in question is actively circulating in the community, you're probably better off getting it sooner rather than later. However, if for whatever reason you still choose to wait 3 months, or your transplant doctors tell you that you really need to wait, then you really need to go back to the old days of COVID prevention, which is social distancing, wearing a mask, and hand washing. The other thing I want to emphasize again in terms of vaccination is to make sure that your friends and families get vaccinated. So I presented some data tonight showing that if you're on dialysis, you're a transplant patient, unfortunately, your immune response to vaccination is not as good as a healthy person. And we really need more research and more studies to do better with that. But what you can do is anyone who's going to be tracking that COVID, that flu, that RSV into your house, make sure that they're taking steps for their safety and prevention. Make sure they get vaccinated. That can really save you from getting COVID or influenza, because whenever I am interviewing folks who come into the emergency room with COVID and the flu, and I ask them, hey, where do you think this came from? They'll almost always point to their spouse in the room or their kids in the room, or they'll tell me, oh, I was at a family gathering, 3 or 5 days ago. So it's usually pretty clear who is giving you the COVID or the flu. And those people can take steps to protect themselves, but also to decrease their chances of getting you sick.
I think somebody commented, Dr. Schaenman, and the same, saying, I'm so tired of people saying it's just like the flu. Anything you would tell them to tell their friends and family, especially if they're a transplant patient.
Yeah, it is and it isn't like the flu. It definitely has some things in common, but some things are different. But the message in terms of trying to create a bubble of protection around the person who has kidney disease or transplant is kind of a similar message.
Got it. Karen asks, she's 4 months post-transplant and wants to fly cross country for Thanksgiving. Is it really very risky?
Yeah. So, with transplantation, the goal is to allow you to enjoy as normal of a life as possible. The quality of life is important. Your lifespan is important, but your health span is important as well. So, traveling across the country to Thanksgiving, it's not a great idea, but you really need to ask yourself about how crucial is this family event to me? If it's very important to you to be around that Thanksgiving table in November, then you need to start taking steps now to decrease the risk. If you feel like, hey, this is my first year post-transplant, I want to lay a little low, be a little careful, maybe do a Zoom meeting, and I'll be there next year, that might be a good choice as well. It's really an individualized risk that you need to think about yourself, discuss with your family, and discuss with your doctors. So if you were asking me, I would say probably better if you are 4 months out post-transplant, not to be on a cross-country flight in November. And remember that now in 2023, most people on the plane are not wearing masks. So you're only kind of unilaterally protecting yourself with your mask, your respirator. And then when you're sitting around that Thanksgiving table, you're really exposing yourself to infection as well. But let's say you would say to me, Dr. Schaenman, this is just such an important Thanksgiving. There's a new baby I have to see, or there's some reason why you really feel that it's urgent. Of course, you're going to get your vaccine now. You're going to wear a mask on the plane, and you're going to ask all of those loved ones who are going to be gathering around the Thanksgiving table to get vaccinated, and maybe to also do a little social isolation the week before your Thanksgiving gathering. You might even ask those friends and loved ones to test themselves prior to your gathering. I think by taking those steps, you could decrease your risk of getting sick, but you're not going to get down to zero. And last but not least, you're going to want to decrease the size of your holiday gatherings. I think that in COVID, we've learned to make some tough choices in our lives. There might be a certain core set of folks that you want to see, and vaccination allows you to see those people. But going to a gathering with 5 people or 10 people is going to be safer than going to a gathering of 40 people or 50 people. So you can make a few just common sense choices that can allow you to enjoy the holidays without really putting yourself in the line of fire for getting sick.
Great. Somebody's asking specific to the RSV vaccine. So is the 80% protection for the RSV vaccine relative or absolute risk reduction?
Oh, yeah, that's a good question. So that's a relative risk reduction. That's a very sophisticated question. You can see that the absolute risk, if you can see the y-axis, is only about 0.2%. That's because the incidence of RSV-associated lower tract disease, like pneumonitis, was pretty low in this cohort of otherwise healthy patients. So that is basically a relative risk reduction. However, as I showed with the data from Korea, although RSV is less common than other respiratory viruses, when it does occur, it really can cause a severe pneumonia and severe respiratory infection, especially in folks with comorbidities. So yes, although the absolute risk reduction is relatively modest, the relative risk reduction is very impressive. And given that this vaccine has really very good safety data, I think that if you have a significant number of comorbidities, it may well be worth getting it. If you're 62, maybe you're on dialysis, but you don't smoke, you don't have lung disease, maybe you're not around a lot of school-age children, maybe you really don't need it. But let's compare and contrast that with if you're 75 or 80 on dialysis or a transplant patient, and maybe you do have lung disease like COPD, that might be a person where you really would want to get that vaccine.
Got it. Thank you. Somebody's asking, my pharmacy recommended, since I'm immunocompromised because of a transplant, I need to come back and get second vaccine in a few months. How often that is, and is that the case for the flu and the RSV as well?
Yeah, that's a great question. So for RSV, I'm going to go backwards with that list. With RSV, they didn't study it in transplant patients. This was healthy community dwellers only. So we're kind of extrapolating that transplant patients would also benefit from this vaccination. There is actually a clinical trial that's about to launch this month from Moderna, looking at transplant recipients, regardless of age, with an RSV vaccine that's an RNA vaccine. So I would say for the RSV vaccine, we really don't know, but once is probably enough. Now for influenza, I focus my comments on the high dose vaccine, but there is also data that getting the vaccine twice can boost your response. That said, I feel that the vaccine literature is already very complex and cluttered. I'd rather you get it once than 0 times. But if you really do want to maximize your influenza vaccine, getting it twice might be better. We don't really know exactly what the spacing should be. The problem is that not every pharmacist is as forward thinking as yours. And so some pharmacists will say, oh, you already had this here, I'm not giving it to you again. So it gets a little bit complicated, but yes, there is data that getting the vaccine twice may be better for transplant patients. Now, going to COVID, the answer is we're really kind of in a data-free zone right now. Certainly with the primary vaccine series and the initial boosters, there was data that getting more than 2, more than 3 vaccines was useful for transplant patients. Honestly, really don't know right now whether that's going to be necessary or not. So I would say, make sure you get that new vaccine, hold that thought, and let's see where we are in 4 to 5 months in terms of how much COVID is circulating, how much the variants have shifted, and what data we're seeing in terms of breakthrough infections, breakthrough severe infections in transplant patients. So I guess 5 months from now is like March, April. So it may be that we're going to end up giving 2 doses to transplant patients. It might not be a bad idea. But again, the most important thing is to get that first vaccine. And I do think that the data is going to show that even for transplant patients, because everybody has had multiple vaccines and a natural infection almost certainly by now, I think that these newer vaccines are actually going to be more effective than the first generation of vaccines. So that repeat dosing may no longer be necessary, but let's wait and see what the data shows.
Next is Dr. Schaenman. Is it safe to get all 3 vaccines at the same time?
Yeah. So the answer is we don't know. So we're recommending no, do not do that. It makes me think of, you know that, is it an Aesop's fable of like the chicken, the fox, and the bag of grain, right? So you can put 2 in the boat at a time, but we don't know what happens with all 3. So I don't recommend it. Maybe it's okay, but we just don't know. There's no reason to subject yourself to that kind of test. The COVID folks tested the COVID vaccine with the flu shot. That's okay. The RSV vaccine people, they tested the RS vaccine with the flu shot. So we know that's okay. But we don't know whether it's good to get all 3 together. So that's why I'm giving you this order of operations. This is your homework and your plan of attack here, is that you start with COVID plus or minus flu. And if you want to do that cherry on top with the RSV, do that as a second or third step. Or go get the COVID shot, and then maybe in 2 or 3 weeks, get the flu shot and the RSV together. But at this moment in time, please do not get all 3 at once. Great question.
Yeah, interestingly, I have one person who's asked 17 questions altogether, so I'm going to try and like club them. But most recently, he asked, like, informed consent is required for all medications, which should include information about a drug's risk. Mm-hmm. Why don't we ever hear experts talk about the risk of these vaccines?
Mm-hmm, mm-hmm. So when you go to the pharmacy and get any vaccine, even a tetanus shot or a pneumovax, there is a handout available that has risks and benefits about that vaccine. And if you engage the pharmacist, they will actually give you that information. Furthermore, when you're making a vaccine appointment, from like CVS or Rite Aid, most of us probably click past it, but there is a screen that comes up that has vaccine risk information. And certainly whenever we give vaccines at UCLA, the nurses will always hand you a piece of paper or offer you a piece of paper that has some vaccine risk information. So why don't we talk about the risks of the vaccine? The answer is because the safety data profile is excellent. For any vaccine, for many medical intervention, there's always going to be a tiny, tiny risk of a negative outcome, of a negative response. But with COVID, the data shows very clearly that COVID will absolutely kill you it will kill you fast, or it will kill you slow or make you miserable slow with long COVID. COVID can affect the heart. It can affect the immune system. It can cause clots and bleeding, as well as pneumonia. And long COVID can cause chronic respiratory problems and chronic fatigue. The vaccine certainly causes some pain at the vaccine site, certainly may make you feel unwell for 24 hours, and very, very rarely, like 0.001%, can cause serious neurological side effects. But it's always risk-benefit in medicine. Hey, getting dialysis has risks, but the benefit is that it keeps you alive for years instead of weeks that you would have with chronic kidney disease. So the reason that healthcare providers don't talk a lot about the risk with COVID vaccine is that the risks are very, very small, and they are very, very small compared with the risk of having a negative outcome or dying from COVID. So it's a very, very easy choice for anybody to get the COVID vaccine, but especially if you have a comorbidity, then your risks of bad outcomes from COVID increase. And if you're a transplant patient, there's no reason not to get vaccinated. There's every reason to take the steps that you can to protect yourself against COVID infection.
Again, I'm going to try and concise these questions. I think they're talking about the side effects of the vaccines too. They commented one study showed 2.5% of the vaccinated had some myocarditis or heart damage. Why risk the vaccine for people with proven natural immunity? And I think in the same context, he asked, why not pre-measure the troponin or like any other markers that would signify before or after the vaccination?
Yeah, I get this question a lot because the myocarditis side effect was so much in the news at one point. So in terms of measuring troponin or CRP, there's no data that I'm aware of that's useful for predicting or measuring myocarditis. So here's the thing, take a look at this slide. Moderna, Pfizer, both FDA approved. What's not on this list? The J&J vaccine is not on this list. Why? Because that's the vaccine that was associated with myocarditis. Now, who got myocarditis from J&J vaccine? It was young, healthy adult males in the 20 to 30-year-old range, healthy folks. So it seemed that there was some inflammation with J&J, that in a very small group of patients, and even in that population, the incidence was very low. And that's one of the reasons I think that J&J decided not to continue offering that vaccine. We have seen minimal to no myocarditis with these RNA vaccines. We've not seen myocarditis with the Novavax vaccine. Where we do see myocarditis is with COVID. We have seen such severe myocarditis that previously healthy folks who are unvaccinated, are in our cardiothoracic ICU on what's called ECMO, so basically cardiac bypass, to support their heart or to support their lungs because they have a complete organ breakdown after getting natural COVID, especially folks who are not vaccinated. So it's, if you look at the side effects reported from vaccines for COVID or for any vaccine, you're going to see a laundry list of ailments that people experienced within the month or two after they got the vaccine. The thing is, when you look at population-based data to say which of these complaints are more common than the average population-based incidence, myocarditis does not reach that level of increased incidence with the RNA vaccines. So I'm very comfortable with all of my transplant patients and all of my heart transplant patients getting these RNA vaccines. Even for the young and healthy, there's a chance of getting long COVID. So that's why I do recommend that everybody get the COVID vaccine. But I suppose it might make more sense if you were 20 or 30 and you just wanted to take your chances with long COVID. Maybe you could defend that. But if you're over 50 and you have any comorbid conditions such as heart disease, lung disease, kidney disease, or certainly if you're a transplant patient, again, it's no comparison. The risk you're taking from COVID is much higher than any very small risk from vaccination. And furthermore, the vaccine side effects seem to be less in older folks and in folks who are immunosuppressed. So you have more of the benefit and less of the safety signals, somewhat ironically, if you're older or if you're on immunosuppression.
Got it. I think there are comments on like incidence of stillbirths being increased in low-risk women from the vaccine.
Yeah. I don't think that there is any reputable data confirming risk to pregnant women with the vaccines. What we do know is that pregnant women are more vulnerable to COVID and influenza, and getting sick can negatively harm the baby. So I think even for a pregnant person, there's no question that vaccination is better than taking a risk with natural infection. Now, that said, I'm not an obstetrician. I'm an ID specialist, and my focus is really pre and post transplant patients. So I think if there's any pregnant individuals out there, they should probably discuss with their OBGYN about risk benefit for vaccines. I think we really want to keep the focus on folks with chronic kidney disease and transplant recipients, where there's no question that the benefit strongly outweighs the risk.
I will take just one more from this list, and that's about low vitamin D levels, because we do see people supplementing a lot. So why isn't vitamin D measured more often and recommended for supplementation to all at-risk cohorts?
Yeah, I think that's a great point. And I think I see Dr. Sarkar is on the call. We do recommend vitamin D circulation measurement, and your primary care provider or your nephrologist will recommend supplementation if your vitamin D levels are low. There is a lot of good data out there that vitamin D and vitamin D deficiency can increase your risk for all infections, respiratory viral infections, as well as bacterial infections. So I am all in favor of taking vitamin D supplements. I forget to take mine sometimes, but that is an excellent idea. But the thing is that having a normal vitamin D level in and of itself is not enough to protect you from getting very sick from COVID, influenza, or RSV. So yes, check your vitamin D level and take a supplement if indicated, but don't stop there if you want to protect yourself from getting sick this winter.
And yes, I will add a comment, because Dr. Schaenman mentioned me that as a nephrologist, we do check it every 3 months and supplement to you to near normal levels if you are under. And then somebody asked an interesting question. That's Andrew. What about hotels that don't have windows, that don't open in the rooms? My gut says find a hotel that has windows that open in the rooms. Your thoughts?
Yeah, that's a very interesting question. First of all, I would say, do whatever you're comfortable with. But we haven't really seen a lot of infections from hotels or other public spaces. The problem is not the room. The problem is us humans. That's where the infection is coming from. It's from the people in the hotel room, not from the room. So I've got no problem with a hotel room that doesn't have a window. I think what you want to do when you're traveling is, when you're out in public with other humans that are going to get you sick from COVID and the flu, that's when you want to worry more about ventilation. Now, I guess if your question is, you're having a party or a conference in a hotel room, then yes, having a window that opens would be great. But if you're just staying there by yourself or with your vaccinated COVID negative spouse or loved one, then I wouldn't be too worried about the window situation.
Great. So I guess that's all the questions, Dr. Schaenman. I would love to thank you with all my heart for such a wonderful and detailed presentation. I think everybody is thanking you in the chat box as well. And I would say this was very informative, even for me as a doctor. So thank you. Thank you so much.
Thanks very much for the invitation. I'm very excited to talk to this group. So thanks again. And thank you for the thoughtful questions.
Fantastic. And everybody, I think we all know that CORE is having a Rose Parade float. The information to support and be there and join us in this great effort is, we're going to post it in the chat box. There it is. It's on January 1st, 2024. So look around, see if you want to join in and maybe support this great cause. So thank you, everybody.
Thank you, everybody.
Bye, everyone. Thank you.